Hi everybody, welcome back to the channel. It's been a bit of a while coming, but we're on episode 7 today and we're covering everything to do with neuro placements. And I'm amazed, well, it's just brilliant to be face to face. And for my first face to face interview, I'm bringing along Alice Brelsford-Ward, who I'm currently working with. She is a team lead here at Plym Rehab Neuro Unit in Plymouth. And today's interview is going to be all about everything to do with neuro. We're going to cover, as always, preparing for your neuro placement, what you might expect on placement, and also how you can get the most out of yourself and out of the placement. So without further ado, let's roll the interview. Welcome back to the channel, everyone. I'm going to start with this awful bit, which I hate doing, but it does really help the channel, which is just hitting that subscribe button, because the whole point of this channel is to get out to as many physio students out there and to give the support that I think is really valuable, and you guys out there are all telling me that's really valuable too. So that subscribe and like, it just gets YouTube to share it as much as possible. So all of that over and done with, I'm really pleased to introduce Alice here today. I'm going to get Alice to give us a bit of a background on what she's doing here and where she came from and how she got to this role a little bit, and then we're going to get stuck into the neuro placement. So Alice, thank you so much for joining me. This is a first interview face to face, so I'm probably going to still carry on looking at that camera.
Yeah,
here.
it's okay.
So just talk to us just briefly, what do you do here at the moment?
Yep, so my name's Alice. I'm a team lead physio on Plym Neuro Rehab Unit here in Plymouth. I've worked here now for nearly 4 years in this job role. Before that, I've worked in the neuro rehab team for a while. I've worked at the University of Plymouth for a while. I have then spent time doing junior rotations across a few different hospital settings. So the RD&E, Livewell, Derriford,
Fab.
So 3 different hospital settings really, and then all the teams that you can imagine within those.
And have you always wanted to do neuro?
Yes. So I've wanted to be a neuro physio literally since the age of 11. So yeah, it was something that I've always wanted to do, and then kind of managed to achieve it on a kind of a permanent basis 4 years ago.
Amazing.
And that's kept me here since.
Fab. Brilliant. Okie dokie. So we're going to talk about neuro placements, particularly for students coming into the neuro setting, which I think can be quite daunting. So if I give my experience, obviously as a band 5 coming into a rotation even, neuro is quite often seen as quite a complex, really intense and quite kind of, you have to have a lot of knowledge and kind of theoretical skills as well as everything else. So I wanted to really kind of break that down a little bit for students and just maybe kind of set the scene. But first and foremost, it's about that preparation. So for students who have got a neuro placement coming up, or they know they will have one coming up, what sort of things can they do to prepare for that placement that's going to help them most?
I guess it depends on the setting. So I would always say get in touch with the educators in that go into that particular role, because say on Plym we see people that have had brain or spinal cord injuries, mostly. So or neurological conditions, sort of weird and wonderful things like. Occasionally we'll have somebody with stiff person syndrome on the ward, and we have to try and Google ourselves and work ourselves out through and do our own literature searches on the physiotherapy management of that person. So neuro is vast, but it depends on the setting really, so it would be, my key bit of advice would be to get hold of the educator and then find out closer to the time what type of patients are on the unit. So for us, we tend to go through phases where we may actually see more spinal patients, more people that may have had traumatic brain injuries, or we may actually have a period of time where in fact we have a whole bunch of stroke outliers even. That's happened before in my time here. So I guess it depends on the caseload at the time, because neuro is so vast, and I think that you can become overwhelmed by trying to learn everything, thinking that you need to know everything, when actually you need to know the people that you're treating here, because it isn't necessarily their diagnosis. I know you've heard me say this before. It's not necessarily their diagnosis. The diagnosis is one thing, the pathophysiology is one thing, but it's a person behind that. You know, they're people. They're people that are, you know, significant event has happened to that's led them to being in hospital, which is, you know, unfortunate. So it's one of those things that you have to, yes, all of the theory is important, but you still have to be that people person. You have to work with that person to know what they want to achieve in order to maximise their recovery.
Yeah. Yeah.
So it is about learning the background reading. Of course, it's important, but maybe try and narrow it to what pathophysiology you're likely to see. So if it's stroke, you need to have a look at stroke. You need to have an overall idea of neuroanatomy. You don't want people to come in necessarily completely like, well, you know, having not prepared for some things, but also the cool bit about the brain is we're never necessarily going to learn everything about it. So putting too much pressure on yourself, thinking I need to learn this in this much detail, you don't necessarily need to go in that level of detail, particularly at student level. You want to be enthusiastic, you want to be, what's the word that I'm looking for? You want to be open to learning, you want to be willing to learn, but also for me, practical application is most important. So learning about what the middle cerebral artery does prior to coming into the unit is one thing. Seeing a person that may have a middle cerebral artery issue and then linking that impairment list to what you're seeing, to me, helped my neuroanatomy knowledge.
So it kind of link those two things together and it actually fits, sort of syncs
Absolutely. So seeing those people, so you can read quite a lot beforehand, but really, again, until you see those people that have had those injuries, it's really difficult to, I think, to really imagine it unless you've got experience in it.
Yeah, definitely. I think just for obviously coming on a rotation, I think that's really happened for me. So for those watching, I've just about finished this rotation after 6 months, and that's definitely been the case. It's been the situation where you hear all these terms, you read all about that kind of pathophysiology and what it looks like, but then when you can take that pathophysiology and think of a specific patient you've treated and what did they have, what were their impairments, and how it really fits together. So
absolutely, and it's not being scared of it.
Yeah,
it's not being scared of it because it can feel overwhelming, particularly on the ward here as well. We see people that are a lot younger, perhaps than your average demographic of someone that might be in hospital. So that can also be an adjustment. So it's, you know, looking after yourself academically where you're doing your homework and you're preparing for it, but it's also looking after yourself emotionally, thinking, okay, preparing yourself for what you might come across, what you might see. And if you're worried about any of that, speak to your educator beforehand. I know I've had students in the past contact me, and in fact I've walked them around the unit before they've started their placement even, just to kind of calm that nerve down. Like they've got an image then of what the hospital looks like on the inside, and any, you know, or even those sorts of things could be virtual if they didn't want to come onto the ward straight away, that kind of thing. So that another preparation for these kind of settings could be the fact that you're going to see a lot of people with a lot of physical difficulties, physical impairments as a result of something that was out of their control. And that in itself can require some preparation. But again, then you're surrounded by the most wonderful MDT when you get here, and you know, hopefully supportive educators and other supportive students, channels like this. All of those things can help you then prepare to see those things and how to deal with them when you do.
So in terms of preparation, obviously one of the things that stands out, maybe it's just me, but I think for a few people, is that assessment. So would you say, is there anything that you could do before coming along, even if it's just really basic and have a foundation, that would just help you get started? Is there anything?
For that assessment? I guess having if you've been taught it before at university, how to do a basic neuro assessment. Now, for me, a basic neuro assessment is it's the actual write-up of the assessment sometimes that I think adds additional value. Okay, so it's the ICF. I'm sorry to say it. I know that students get taught it, and I know that it's not always doesn't always feel like a productive use of time when you're writing down someone's problem list. But I've found that foundation when I've done an assessment to really think about what that translates to in an ICF. So if somebody can prepare not only about what they think that they might need to assess, they don't need to be perfect at it. That's exactly why they come into these settings. They don't need to be even good at it, but have a basic knowledge of it. And then, you know, those are the skills that we would refine with the students while they're here. But having an idea about what the ICF is, because I'm a fan of it. And I think in neuro settings particularly, it really helps because it builds the impairments. It influences how that, you know, person might be able to do activities, and then the participation, so why they're in hospital in the first place, why they can't return home perhaps, and also the environmental factors that are keeping them here. Particularly at the moment, you know, we have, you know, I don't want to mention COVID too much, but at the same time, it's meant that visiting in hospitals is really limited, and that environmental factor in itself, or the personal factor in itself, where people aren't seeing their families as much as they want to be in these situations, can be really tricky. So it's having an understanding of the ICF and how that then will relate to people when you write up your assessments. Yeah,
so it's not
worrying about neuro tips all the time, and
exactly.
you know, so it's not thinking, am I going to use cotton wool or neuro tips in this situation? That is, of course, it has its place. Of course, it has its place, but we can refine that. That's more than basics sometimes. You know, when it comes to actually, you know, doing assessments.
It's just, and I think, no matter how much we say it here, I still think cotton wool buds neuro tips. We today actually, myself and one of the band sixes here, Lee, we went through a neuro assessment with the students, and the first thing I did is I picked up a reflex hammer, and Lee looked at me and went, "Don't do that." What? Yeah, and it's like, it's just that thing whereby when you're a student and a new grad, you're always going for those objective things that you think you need to use, rather than some of the other stuff that you're talking about is actually far more important. We talked about also building up that rapport as well with the patient, which we're going to get to like in a minute, with the expectations of what you might do, etc. So that's fab. So kind of actually there's not a huge amount of preparation that you have to do. Just make sure that you know what you've been taught, just revisit it, make sure you're relatively familiar with some of that stuff.
Subjective and objective assessments, you know, and again, it would change depending on what setting you're in. You know, if you're going to see Parkinson's patients more often, perhaps in an outpatient setting or in a community setting, you're certainly going to ask them slightly different questions that you would perhaps somebody that's had a stroke, because you want to know about the, you know, because you've got a basic understanding maybe of the differences between those pathologies and why you would ask different questions. So it's the subjective assessment, the objective assessment, but on a really, you know, foundation level, because then everything that you learn on placement will help build that. And then when you're qualified and you're out in practice, then you build you just build and build and build. You don't have to turn up with neurotips, cotton buds and a reflex hammer doing Babinski tests on everybody, because although they're wonderful skills, actually, you know, until the other skills are refined, you wouldn't necessarily need to use those.
So that's foundation as well, isn't it? And that's something I've talked about, I think, and lots of people that I've had onto the videos have all talked about. If you haven't got that foundation, it's really hard to then build the walls to have a really good, firm building. So that's really important. So.
And communication.
Fab.
Communication in assessment is key.
Got to talk to patients.
You do.
Get to know patients. As you said right at the beginning, they're people.
They are people. They are not scary. Sometimes you can read a referral and think, oh my days, what am I about to see? And then you go meet them and you're like, oh, you're a person. You are a human being. You are a human being. You are a person. You are not a pathology. You are a person. And remembering that, treating that person like a person, explaining everything that you're going to do to them, do with them, you know, what you're assessing, talking through things. Even if that person's not able to respond to you, communication is really, really key, because if you were unable to respond in a situation, you'd like to hope that that person was explaining what was happening all the time. So, communication is really, really, really key in these settings, and it's adjusting it, you know, with what you might be seeing.
Fab. Okay, brilliant. Right, we covered really well there how to prepare. So let's get on with what you might expect to see on a neuro placement. So let's talk about the expectations on what you're actually going to be doing on placement. Now, obviously, this is going to be different depending on the setting, whether you're working in, obviously, inpatient, outpatient, acute, community. But just as a general, from your experience from students, what sort of things might a student expect to see and do on a neuro placement?
Again, you're right. It does really depend on the setting. So in say this setting, I'll start with this setting. We are lucky enough to timetable. we timetable as a way of making sure that that person, the patient themselves receives the amount of therapy that they should receive from each of the different disciplines. But because we do that, it does give us a bit of flexibility with students to actually block out time for them.
Yeah.
So something that they might expect in some settings is, okay, so you're seeing this person, then you have a block of time out, as opposed to in some settings where it might be that you do a whole morning doing something, shadowing, and then have time away. Actually, sometimes in neuro settings, you might spend time with the patient, then have a bit of a break, whether that's to write up something, so you've got extra time to write notes, or if that's to go through something, reading medical notes, Googling pathologies, those kind of things, depending on what it is really. So we can be a bit more flexible in these kind of settings, and that's sort of true in outpatients as well. A student going into a neuro outpatient setting or any outpatient setting might be given, because it works in sort of, chunks of time, slices of time, if you will, rather than it being that they're going to have to eat the whole cake. They might just be able to have a slice at a time, and that can really help. And I guess it's depends on the student. So if they come in and they think, whoa, that wasn't what I necessarily expected, then it's having that frank, open, honest conversation with your educator to be like, can I slice my time? Can I have this? Can I have that? And not be afraid to ask, because it feels awful when you're an educator and you think, oh, I didn't know that you were struggling doing that until even a couple of days in, because you don't want that student to be going through stress. You want them to be enjoying it, like maximising their learning and just loving it all the time. So if they're struggling with something that can be changed, tweaked, then it's always important for that student to be honest, really.
And it can't be tweaked if you don't know about it.
No,
we say it all the time. Everyone I've had on has always said about this.
Please just tell us. Please just tell us.
Cool.
Yeah, and I guess expectations of what you would see on the unit here. So on here you would see, as I said earlier, younger people, perhaps with brain and spinal injuries. You will also see people that are older with similar injuries. But it is that kind of, that is slightly different, isn't it? Having people that are younger in terms of what you might expect to see there. Okay, so maybe in a stroke unit, for example, you may see a demographic of people that may have additional comorbidities. For example, things that may have been risk factors that have led to them having a stroke in the first place. Perhaps, not always, but kind of maybe a few more things in their past medical history that would predispose them to being on the unit. And then in outpatient settings and in ES, if you're in an early supported discharge team, so again, stroke, but in the community, you might see people that are slightly physically require less support because they are able to manage in the community, more able to manage in the community. But that still comes with a lot of challenges, and it's looking at that higher level, maybe that's higher level cognition, working a lot with the OTs, and it's working on goals that are more outdoorsy, getting that person back to doing the things that they...
Participation part of the ICF stuff?
Yeah, absolutely, because it can be really tricky in hospital settings because people, research tells us that people in hospital don't do very much. In fact, they're grossly inactive, which breaks my heart, but it's fact. And so we all work hard to increase activity levels as much as we can, but there comes a point where these settings will no longer benefit that person, even whilst they're still recovering. And home is the right place. And when home becomes the right place, that means that they need to be challenged in a different way. So your expectation would change in what you might see based in inpatients versus outpatients and versus the community.
Yeah, definitely.
Yeah. And perhaps people in the community may even be further down the line at times. So they may have gone through an acute setting into a rehab setting and then kind of, be however many months post-injury or post-stroke before they're then discharged home, and in which case the speed of recovery might be different. So you may see changes that are really important but may be slightly slower compared to if you're in the acute setting. And someone, or here, and suddenly you'll see somebody that might all of a sudden make huge bouts of recovery. So depending on the setting, kind of fits as to where, from a plasticity perspective, where maybe you would expect the speed in recovery to alter a little bit. depending on how long post-injury they are, or post-stroke. Or
and I think I always like to be brutally honest on these, because I think there's no point sugarcoating stuff. I think the more students are aware of what they might expect. And I think one of the things that can be quite challenging is obviously the behavioural changes that you might see with people particularly with brain injuries. And also to cover, I think of it, the emotional impact that these injuries and spinal cord injuries can have on a patient. So what might a student expect to see and experience in that respect?
You are likely to see, if you're in particularly in this kind of setting, people having had probably the most significant life-changing event. So they could have gone from being a completely independent person to having all of that stripped away in one moment. So one stroke, or a spinal cord injury, which it's that adjustment time. So that person is going through a real change. And I think, again, I'm going back to COVID again, when we have had less visitors on the ward, I think our role as therapists has altered quite a bit. I think we have real long length of stays here. So I think our average length of stay is just shy of 70 days on this unit.
Right, okay.
So it's between 60 and 70 days. It does fluctuate a little bit. And if you think about that, that's 2 months. Now, if you were to stay anywhere for 2 months, you would be like, I don't know, that place would start to feel quite familiar, wouldn't it? The people that you were seeing every day would feel quite familiar.
Definitely.
So our patients go through that huge life-changing event. They then may stay on a ward such as this for a set length of time. And then the therapists, the nursing team, everybody that's working with that person suddenly becomes part of their family. Because they can only see their relatives for an hour once a day. Exactly. That's our current visiting policy. I mean, obviously that's not necessarily normal, but it's our current normal. So I think our role has altered a bit in terms of what to expect would be perhaps a little bit more emotion than, but both ways actually. For us, I think we then absorb a lot. We ask more in-depth questions about really how people are feeling, because they're not getting the same level of outlet that they used to. I mean, that again, that's an opinion of mine as opposed to a fact. But
you see it, don't you?
You see, absolutely, and it can be harrowing at times. But the staff, how we look after each other here is through reflective practice sessions. We're really lucky to have a psychology team on the ward here that are just wonderful and will help us digest what we're seeing, because what we see is sad. And you cannot be outwardly sad in front of the patient, because the professionalism, you have to keep that element of professionalism to a point, bear in mind, you get to know people a fair amount on the ward, you can't be too professional all the time. But it's learning, it's thinking about that you might see some really, really sad things. You might see some people that have got, horrific injuries that are obvious. Physically obvious. We have people here that have craniectomies. Now, the first time I saw a craniectomy, it turned my head. I was literally like...
Almost,
Almost.
So just to clarify from a point of view, so craniectomy is... Just
when a chunk of the skull has been removed. And that will have been done in an acute situation. Somebody has a brain injury and it relieves the pressure that's building up underneath the skull. So you literally lift the lid of the box, allow the pressure.
So you look for the first time you see that's going to be something that's going to take you back maybe quite a bit. So.
Absolutely. So things like that. And sometimes we have some orthopaedic stuff going on, pins and all sorts of things if people are multi-trauma patients. So you might not just see the result of those injuries, you might literally be able to see those injuries, if you see what I mean by that.
Not just necessarily inside, which has its own problems as well, doesn't it? When you can't see the injury itself, it's not as obvious. That can have the same problems.
And the behavioural stuff, that's what you asked as well. So challenging behaviour. So it's having that understanding that person is not purposefully acting that way. So we see a lot of people that are essentially filterless, if you like, in their behaviours, in their speech, in their in all aspects of what they do. And that level of understanding that you kind of have to develop then is, okay, that person is challenging, but not intentionally.
No, it's not them.
It's not them. It's their injury. It's the result of what's happened to them. Yeah. So it's having the patience and understanding, and also trying not to be too fearful. Because it sounds on paper that someone might be quite disruptive or quite scary almost, scary. And in certain moments, perhaps that is the case at times. But generally, that's somebody recovering from an injury. Yeah. It's not an actual chosen behaviour that they're portraying. So there's that to not always expect. Again, it really depends. Really depends on where you are, what setting you're in, what the typical injury might be of the people that are in there. And there are legal, there are legal and protective frameworks in place for patients and staff, So we have lots of things to help us in these situations. So it's also not thinking, I'm going to be on my own, I'm going to be doing this. You never will be. No. There are things that are in place, particularly as a student, to protect you all the time.
So no one's going to put you in a situation that you don't feel safe in, or you're not competent to be in the first place.
No, absolutely not. And it would just be exposure to those things. It would be an exposure, but it wouldn't necessarily be a.
There you are.
Yeah. Thrown in the deep end.
So, and also I'm thinking from a neurological point of view, there's some other things you might see. It's not to forget, and I'm always a big advocate of this, is as physiotherapists, we're not just a neuro physio or a spiritual physio or an MSK physio. And I think I found that even more on this rotation, that your skills in respiratory, MSK, as a physiotherapist are really important. So you do see those things with respiratory trachees and things like that as well, don't you?
Absolutely, yeah. So it is thinking about if somebody's got neurological weakness, that's going to affect all aspects of their systems, isn't it? So whether that's somebody's ability to cough, so they may need support with their like a cough assist or something like that. Whether that is that person's ability to simply cope without having a tracheostomy. So we have lots of people that have tracheostomies on the ward here as well. And like you say, musculoskeletal things. So as I've already said, we have a lot of people with orthopaedic issues. Yep. So you've got your orthopaedics side of stuff. But then you have, when you're in a neurological setting, it can be very easy to think we're thinking about the brain's communication with the body. Mm-hmm. We're not so worried about the actual arms and legs. The arms and legs should be working. It's the brain's ability to communicate with them, whether that's at a brain level, or a spinal level. So that's the issue. There's a communication issue. Yep. Sometimes we'll get both. So sometimes we'll have a brain issue, a spinal issue, and an orthopaedic issue. Yeah. We'll have all three of those things going on at once. Yep. Or what you will have is somebody that's got a brain issue, but at the same time has been in hospital for 3 months on an intensive care unit perhaps already. So that's 3 months worth of deconditioning and all of the nasties that come along with that. Yep. And also then there will be lots of musculoskeletal changes, whether that is muscle fibre type. I know we've talked about that recently, haven't we, as well, or just general stiffness in a joint, things like that. There are lots of things that you need to have an awareness of. So the actual musculoskeletal injury side of stuff, yes. Yeah. But it's all encompassed. And again, it sounds scary and it sounds complex, but it's not. It's that person. It's just a person. Yeah. You write your problem list down. You work out what's important to that person. You work on the things that are important to them. Definitely. In the most caring way that you can. Yeah. With a sprinkle of physiotherapy, and that sprinkle of physiotherapy is the nag.
You kind of use that to enhance your ability to care and
exactly,
for that person, definitely. Yeah, fab. That's it. So there's so much, obviously, depending on which setting you're in, and I think that just enhances the point you made earlier about talking to your educator early on and getting in touch with them, finding out what kind of caseload you might expect. So your expectations are you're going to find out. Not just from this today, but also actually just talking to your educator beforehand, isn't it? And not be scared
Definitely.
to do so. And if you want more information from them, ask them as well.
Yeah, always.
Definitely. And I think the other one I always say is talk to students who've been on the same placement as well. Yeah. Usually people have been on that placement, you can get in touch with them as well and find out what sort of things. But the patient group you'll see might be different to the one that they've seen as well. As you said, there's a different changes all the time. So it's just...
Exactly, and if you're in a different year or a different stage in what you've been taught before, and you know, there's also different expectations from an educator perspective.
Yes.
You know, from at what point that person might be in their degree as to what you would expect them to maybe be able to do.
Definitely.
You know,
or where they are in their development. You know, we have second years that are maybe at a further on stage than an early third year as well, don't you? You do have everyone. It does develop at a very different level. Speed. So.
No two students are the same, just like no two patients are the same.
Exactly, definitely. Fantastic. So that's a good overview of expectations.
Yeah,
brilliant. Now we come on to the one that I think really, really helps as well, is about how a student can get the most out of themselves, but also the most out of a placement whilst they're on placement. What are your kind of tips and advice for students going into that one?
First of all, it's not focusing on marks.
What are marks?
Grades.
Exactly. Yeah.
I actually answered that then, didn't I? No, so don't focus on grades.
Yeah.
I think that's something. If you come in thinking, oh, I got a first in my last placement, therefore I want a first in this placement. You know, I think it's really hard because I know that the majority of the time placements are going to be marked, they're going to be graded. You're going to be scored on a scale of how, you know, and it's going to go towards your degree. And I appreciate the impact that might have of a driver towards wanting to get the best mark you can get. But if you work towards being the best physiotherapist that you can be on that placement, the marks will come.
Definitely.
You literally, if you're thinking, I'm going to read this article because I want to get a higher mark, that's not the right attitude. You want to be reading that article because you want to learn the information in that article so you can apply it to your patients to be a better physiotherapist. So that is my biggest thing is stop focusing on marks. Do not focus on marks. Focus on the things that you want to learn. What do you want to learn in that placement? What do you want to learn? I mean, I relatively recently had a student who really wanted to learn manual handling skills and was really honest with me at the beginning. Now, perfect. You know, what better place? You don't know neurological weakness until you've felt a neurologically weak lower limb on a 6'2" guy, you know.
Limbs are heavy.
Limbs are really heavy, yeah. So I guess for me it's thinking about things that you want to learn, and then your educator should be working then to help you facilitate that, to really, you know, if you say, oh, I really want to learn about the role of the MDT, great, in which case your educator should be allowing you then to spend time with the MDT, you know, and learning about those different roles. It's one thing that in most neurological settings, that person's not going to have a sole therapy need. They are 9 times out of 10 going to need physio, OT, speech language, psychology, the nursing team. You really think that, so if you learn those roles in those situations, it can be really, really useful. But yeah, overall, I went off on a tangent then. Overall, stop worrying about the marks, learn to be a good physiotherapist. And it is, I know that as well, people like to say, focus on assessment, don't they?
Yeah.
And assessment is really important because it gives you a good foundation. You write a problem list, you write a plan. Your plan is then easy if you've done a good assessment. Because you should know then the treatment-ish, the idea of what things you want to work on at least, even if you're not yet sure about what treatments you would use, you would be like, these are the problems.
What am I going to do?
What am I going to do about it? What are my options? Yeah, exactly. What's your toolbox? What's in your toolbox?
Which as a student might be really small. But
and that's okay.
You're going to grow that toolbox, so yeah.
Exactly, and every time we rotate, and every time we have a new patient on this ward, every person's toolbox grows. Everybody. Yeah, so the toolbox, it will grow, you know, depending on the amount of experience that you get, your mileage, if you like. Depends on your mileage. And I suppose my advice would be to spend time with lots of different therapists. Not one therapist that you work with is going to be... So every time I work with somebody new, I find that I will hear something that makes me go, oh, I like the way they asked that question. And when you're doing an assessment and you're learning how to do assessments, the more different people that you see do assessments, sometimes that can feel overwhelming because you think they did it differently. They asked that question differently. They did that part of the assessment differently. What's right or wrong? it's not necessarily there's right or wrong, there's just different approaches. There's no black and white in these situations.
There's no hard and fast rule.
No, there isn't. So you've got to find your feet really, and be okay with that. Find your own rhythm when you're doing assessments. Find your own way of asking a question that makes you feel comfortable, or way of doing a physical assessment that makes you feel comfortable. And then that good assessment foundation will help. We have difficulty on Plym really of giving students the mileage that they need to achieve a sound new patient assessment, because our turnover isn't huge. As I said earlier, we have, our length of stays, we've got 15 beds and our length of stay is nearly 70 days. So in terms of that versus maybe an acute stroke unit, where you'll see, left MCA after left MCA after left MCA, because you would, different recovery, you're bound to, you're going to see a lot more strokes in comparison to the turnover would be much higher than these kind of wards. So it can be really hard to develop that actual assessment or feel that you've developed that assessment. But it's the holisticness, I think, of what we see here in terms of our assessment won't take half an hour and you don't need to achieve it straight away.
No.
So the other thing is taking your time. Depending on your setting, you've got time to work with that person, learn them as a person. I know I keep going back to it, but these are people. Learn that person, and then you learn how to speak to them and build a bit of rapport with them. It's really important. Give a bit of yourself away.
Yeah, you said that a lot to me when I've been here. Yeah,
true. Give yourself away a little bit, just a tiny little bit of information, so you might be able to relate to that person. Research tells us rapport means that when you're building rapport with the person, they're more likely to comply with what you're asking them to do. If you trust your therapist, you're going to want to do it, aren't you? You're going to
get that buy-in, don't you?
Yeah, exactly. So you need to also, in terms of it's having that ability to communicate with somebody, giving yourself away a little bit so that you can get to know them as a person, they get to know you as a person, and actually that can be really valuable in terms of not just the assessment period, but then the treatment period, and also when it comes to following them up, and you think, how did that go, by the way, yesterday? Remember those bits of information if they told you, learn their whole story. What are they doing in OT at the minute? What are they working on? That can be really important, because if you say to them, that you're not their sole, you're not their sole driver for being in hospital. There's lots of other professional groups they could be working with, and acknowledging all of that all the time makes everything that they're doing feel like it's got value.
Yeah. You're acknowledging everything else they're doing as being worthwhile and
absolutely, and also journey. Understandably why someone might feel really fatigued. That's something else to expect. I know that's back to expectations. Fatigue in neuro is huge. Definitely. The brain has to work very hard. It's like exam time all the time for our patients. Constant exam fog, brain fog, cognitive fog, constantly.
So many different things, but so many
over and over. Interrupted.
Left, right and centre, whether it be for ops or whether you want a cup of tea or a biscuit, which is, they're always being bombarded, aren't they?
Constant bombardment.
One thing I'm going to do the same as you've just done a little bit and go back to expectations, because I just wanted to cover the MDT side of it, because that, I think, for me on this rotation, so just again for the video here, I never had a neuro placement, so this is almost kind of been a double whammy for me. But one thing is the MDT, which I love working with MDT, but it's been so important here as well. So as a student, kind of that MDT side of thing, I just wanted to emphasise that on the expectations, as you probably will be working with lots of different professions. And respect each and every one of them as well. Professional tribalism, that's a term. That's official terminology. You can check that out. Professional tribalism exists, and it shouldn't. And I think this ward is one of the best places. Well, it is the best place I've ever worked where that tribalism doesn't really exist. People actually sit together in the staff room. It's bonkers, exactly. Whereas you can sometimes go into some places and you'll see that team sits there, or the physio sit there, the OT sit there, and the nurses, well, they're never to be seen, because they don't mix with therapists in some places, and it's just bonkers. Whereas we're lucky here that our professions really, really respect one another. Which is how it should be.
It's
only one person that matters, isn't there? And that's
Absolutely. So it is learning the roles of your colleagues is so important on placement. So important, because it will give you a whole new level of respect for what everybody's doing, really. And neuro settings are kind of perfect for that.
They are.
Really.
This setting I've experienced. Definitely.
Can I ask you a question?
Go for it.
Is Plym what you expected it to be?
Oh, that's a really good question. So, yeah, it is pretty much. Yeah. So I looked at what the patient groups were before I came on my rotation here. I emailed you, and near the time you sent me through some idea of obviously anonymously what patient groups we had, and I was able to kind of have a look at that. But I think nothing. This is going to sound really contradictory to what we've been talking. I think nothing prepares you, really, until you've got there and you've gone through the door that you don't know where it goes to, and you gradually understand where that door does lead to, and what that bay looks like, what are the beds like, what kind of equipment do they have, what are the nurses like, what's the ward manager like, what are the other physios like, and all those things that just...
What does it feel like to hold a densely weak limb?
Yeah, exactly.
Because you don't get that
hold
experience.
Someone who has truly not got any sitting balance, what that actually feels like, that you're using every single sinew in your body to keep that person sat up, and you just have a massive appreciation of how complex doing what you and I are doing right now.
Yeah.
It's just amazing. It does give you a newfound respect for the human body as well. But no, I think overall, definitely, it's exceeded my expectations 100%, because it's kind. In terms of, I think like you said, this Plym Neuro Rehab Unit is it's a team. I've heard a lot of teamwork gets branded around all the time, isn't it? But then when you really get into that team, you think, why are they over there? Why are they over there? They're not talking, or so-and-so's talking about someone else. That just doesn't happen here. And you just get that feeling of everyone's working together for that patient, and everyone has an idea of what each other does as well. And that's makes a big difference when you see it come to fruition with the patients. Yeah, definitely. So it did. Definitely. Exceeded.
Good. Exceeded. I'll take that. You can snap it, cut
that
bit out.
In there,
For me. Just send that to me separately. I'll have that.
So that's... kind of how to... Is there anything...
Maximise your learning.
Yeah, I think whilst you're on placement, definitely.
Yeah,
there's a couple of things on that, I think.
Yeah, maximising your learning also on placement is about asking questions. Mm-hmm. So really, really try not to be too worried about asking why. Why are you doing that?
Yeah.
Why are you doing that? That's okay. Mm-hmm. Educators will not be offended. And if they are offended, then they shouldn't be. No. So that you want... I always appreciate really, students, and I think it can put educators on their toes a little bit, because they think they have to think themselves. Sometimes we do things very automatically, and we really don't think. If I take the likes of, say, Pauline, who's worked here forever, and everything that she does is so automatic, unless you ask her why, and then she can give you the answers,
So
and
I think stop and go, what am I doing?
Because she won't know where her hands have been, because they will automatically go there in terms of so how she's supporting someone, what she's doing, where she's what she's doing to facilitate movement. So it's really important to ask why. Why are you doing it that way? And also then I'll ask for feedback sometimes about how you might have gone on. Sometimes students can almost expect an educator to give them feedback all the time, but I've been in a situation before when I was a student where I felt like I had an educator giving me too much feedback, so I never wanted to ask, because I was like, it can be quite overwhelming. I don't want to know. I don't want to know anymore. Don't tell, because that made me feel like I wasn't actually doing very well. But it turned out that the feedback was actually to keep pushing me. But at the time, it felt.
And ultimately, that's what it should be, shouldn't it? It should be constructive. It should be moving you forward all the time.
Absolutely. So as a student, you kind of know what level of feedback you may or may not appreciate. Sometimes you can think, I'm not getting enough. And if you think that internally, please express it. Or you can think, this is too much, this is too much, this is too much. But you don't want to say that, because you think, I don't want them to think that I don't want feedback.
It's a really hard conversation.
It's a hard balance, actually, isn't it? It's a really hard balance,
I suppose if you've been on placements before and you've had what you do and don't like, that'd be a really good chance to go on the next placement and talk to your educator really quickly about that. In terms of feedback, would it be okay if I had feedback after each patient, or would it be okay if we sat down and had feedback at the end of each day, or at the end of that would be really impressive, wouldn't it, if a student came up with that kind of foresight. But if it's your first placement, I suppose it's just being honest as you go along.
As you go along.
Yeah.
And you're trying to find your feet as a student in that situation, and the educator knows that.
Yeah.
They appreciate that.
Exactly.
They understand that it's really overwhelming. The first placement can feel really overwhelming. You know, you may not have actually ever been in a hospital setting before.
Yeah, that's it. In any shape or
in
form.
any no, and it happens, and it's just not being frightened to be honest about what your learning needs are and what level of feedback you might want.
Yeah, definitely.
And like you say, that might change throughout the placement, but that's okay as well.
Absolutely, yeah. And having that awareness of it and being honest. I think the other thing to always remember as well is that your educator wants you to succeed.
Yeah,
they want you to do
definitely.
well. They're not trying to catch you out. They're not trying to find flaws in you. They want you to be a great physio, because I think one of the things you do see is physiotherapy is such an amazingly supportive profession. Everyone wants each other most of the time to do well. So in your educators with students, they want you to do well. So talking to them about how you might do better is always going to be a good thing, isn't it?
Yeah, definitely. I think from a professionalism perspective, I always quite like to, I would expect a student to act like they would in a job interview.
Mm-hmm.
So, you know, the things like the punctuality, looking smart, you know, there's lots of things that professionally you can push. You know, we joke in the office, obviously we do, we're human beings, and we also see some sad stuff, so we have an element of
an outlet almost.
Of kind of wanting to get that off our, off our chest a little bit. And I think as a student, sometimes that can be quite a challenge when you're in a situation where you think, you know, this isn't necessarily, you know, when you're trying to be professional and the professionals are not being as professional as you perceive that they would be. Because again, sometimes I think people forget that educators are all humans. We are just people. Exactly. We have weekends and evenings too. You know.
Exactly.
So it's getting to know the team and knowing your role within it, you know, and fitting in it, you know.
Take the time to find that as well.
It can. It can.
Some people that's harder than others, and everyone's just different.
Yeah, definitely. And it's just treating each day on placement like an interview. You need to be there on time. You need to be smart. You need to be engaged, enthusiastic. You want to be willing. You know, just be willing to learn.
Yeah.
And if it isn't the setting that you fall in love with, I mean, I'd love to think that everybody that comes to Plym or goes to a neuro setting falls in love with neuro. Unfortunately, I know that's not the case. But, you know, I'd like to hope that was the case, really. But then it's only a placement.
Yeah.
So still stay engaged. Still, you know, that's not permanent, is it? And when you qualify, you go into rotations sometimes, and you may take less out of some rotations than you do others, but you still take stuff out of everything. You learn in every single rotation that you ever do.
You do, yeah.
So placements and having multiple placements is really important for that.
Yeah.
So even if, say, neuro isn't, you know, you're dreading it and it's not what you want to do, and you know that, and you are set on that, that's fine. But still think, I can still learn here. I can still learn stuff, and I still want to learn stuff.
You know, I think that's the other thing. I harp back to about this physiotherapy being everything you do. If you want to be a respiratory physiotherapist, that's your thing, and you think, I'm going to do neuro. Well, if you're thinking that for the rest of your respiratory career you're not going to see neurological impairments and neurologically impaired patients, then you're going to. So you're going to have
need to learn
the more you learn on that, the better respiratory physio you'll be. And the same with MSK. You're going to get people who had a stroke and then come to you for NEOA or something else, or Achilles tendinopathy. So it's the more you know and more you take from each placement, the better. Because you'll be able to take it into the areas that you do want to go into, regardless of how much you love it. So I completely agree with that one for sure. Final thoughts. So this is the bit where we just basically add anything on to what we've already said there. Anything else you think it's important that students know about or have information-wise before they go on placement? Yeah,
I guess it's not going to be easy.
Yes.
I would say that. I would say that because it is essentially, you know, you've got to work for however many weeks your placement is. And I've been in a situation before where when I was a student, I didn't receive too much funding, you know, for when it came to placements, which meant I had to work.
Yep.
So I worked Saturdays and Sundays, and I worked the Saturdays and Sundays and commuted to Redruth on a train.
Which is how long?
Oh, yeah, good point, because this is more than
People in
Plymouth.
Australia watching this.
Okay, so I had to catch a train at 5:45 every morning to get to placement for 8 a.m. So it was about an hour and 45 minutes on the train or something like that. But I also had to walk to the train station, which took an additional 20 minutes. So basically I was leaving the house at about 5:20 every single morning, and I wasn't getting back until gone 6 p.m. And then I worked Saturdays and Sundays, and I did that solidly for a full 5-week placement. So not a huge placement, you know, it's not a 10-week placement, but a 5-week placement. Did a stint of that.
Isn't it? Yeah.
And I think I used that was hard work, but I used the train journey to actually sleep on the way there.
Yeah.
Obviously, because it was very, very early. On the way back, I wrote reflections.
Yeah.
I searched everything that I was learning about. You know, I used that time really well, so that actually, even though I didn't get home till 6 every day, when I got home, I'd had an hour and a half's worth of post reading, you know, post that day reading, whether that was right, you know. And educators love to see it. They love to know that what you've learned about in the day, that you have then gone home and perhaps just in, you know, it doesn't take long. Information's literally at our fingertips now.
It is, yeah.
You know, like you can literally Google things on your phone, on a bus, on the way to going anywhere. So I think it's looking up information, then coming back and peacocking a bit, for want of a better word.
Yeah, and that's that.
For want of a better word.
I think a few others on these interviews have said about, you know, yeah, literally that peacocking.
Peacocking.
Tell us what you've read. Tell us what
Show us your feathers.
Yeah.
Show us your feathers. Tell us what you have read about. I think it's really important. I think it's a graft. You can, of course, say to your educator, you know, I said earlier about having chunks of time and say, look, I need this chunk of time to digest what I've seen, to digest. That's really valuable to do.
Yeah.
I think it's not going too far the other way, where you then get less clinical time because you are information gathering in a situation where you may have been able to do that in an evening a bit. But it depends, you know, it really is, and that's what I mean, it's flexible, being flexible with your time a little bit and honest with your educator about what you're struggling with, perhaps, you know.
It comes back to communication, doesn't it, with the educator?
100%. But, you know, educators do love to see students that may have, in their own time, just read an article and then told about it and been like, oh, so I've read this about, you know, using electrical stimulation for muscle tone. And you'd be like,
brilliant.
okay, should we do it?
Yeah.
Should we do it and see if it works?
Yeah.
And then that student might get that bit of feedback where they've made a suggestion that's then been used, that's maybe benefited a patient, and then that internal learning. As a qualified member of staff, when you get that degree, learning carries on forever, and nobody will give you necessarily chunks of time to do it, and you have to get good at finding information out for yourself and applying that information yourself.
Potentially in your own time.
Potentially in your own time.
Yeah.
I've had to write so many in-service trainings in my own time.
Yeah.
Like, I would say 95% of them I've written in my own time. So you just...
But it comes back
that's
to
normal, isn't it?
Finding something you love as well. The way of doing it in your own time, you know, within reason. It doesn't necessarily feel so much of a chore as...
If you're geeking out and you're absolutely loving what you're writing about,
Find what you love. And that also comes back to that bit about being inquisitive. You know,
yes,
if you find something you're interested in, go away and read about it. Read about the bits you want to, and then have a talk, because you should be able to, your educator or any other, the physios and the physiotherapy assistants, etc., chat about what you found and what you liked about that stuff you read, or what you didn't like about it, or what you didn't understand as well. Because you might really read something, I read this article, but I didn't really quite understand this bit. Can we go through that at some point? Again, that's the same thing, isn't it? Whereby you've been proactive about going to source information, found the gaps of what you didn't quite understand, and then using the time with your educator really well to fill in those gaps.
Absolutely. Proactivity is a very good word. Yeah, very good word. Definitely. People, you know, educators appreciate proactivity because it can feel really hard. You don't want to be, as an educator, having to be the person to constantly instill that drive and motivation into a student. You want that student to come with an element of that as well, if they're able to, and I appreciate everybody's got things going on in their life and things, and it's not always that easy, but if they're able to have that element of enthusiasm and being proactive is really, really key. The other thing's enjoying it.
Yeah.
We need enjoyment.
Yeah.
Like, you are here to learn.
Yeah.
That's it. You're here to learn.
Mm-hmm.
Great. You imagine having a chunk of time and someone just said, you've got 5 weeks, you're there to learn. You'd be like, okay. Like now we get 3 CPD days a year.
Yeah.
That's, you're there to learn. So it's prioritising your learning, exactly. Prioritise your learning over everything else. And it's a hard transition from school to university where learning is paper-based to learning being person-based.
Yeah.
So it's trying to find that balance where you are still learning when you're working with people as well all the time.
Yeah, absolutely. And I think also, when you talk about having fun as well, I think takes time to learn, but also have fun with your patients as well.
Oh my God, yeah.
Yes, there's a professional line, absolutely. You wouldn't necessarily have fun with your patients like you would with your mates down the pub or etc.
I mean, we're not going to drink with our patients.
But within reason, definitely, because you can imagine if we talk about people being in the hospital setting for a long period of time. There's nothing more refreshing than actually just having some normality, and that might be just a few jokes or just
laughter therapy,
conversation and
laughter therapy.
Absolutely.
Yeah, absolutely. Laughter therapy, music, being outside, or use all those tools. You think about things that you would want if you were stuck in a hospital setting. Exactly, like, what would you want? Well, I'd want someone to, be a little bit just cheeky and fun, and somebody to get on with as well. It's all those things. It all matters. It all matters.
It does.
So. And
there'll be some patients I think you find that easier than others, absolutely. And we're all human. We get drawn to some people more than others.
Mm-hmm.
But definitely finding that common ground. And you said earlier about giving a little bit of yourself away, that can really just help bond you with a patient, and just that kind of that fun can happen as well, and just enjoying. And the more you enjoy your job, the better experience the patient will have as well, because no one wants to see someone who hates their job. It's nothing worse.
We've all been in situations where we've been around people that clearly don't like what they do.
Just stop being this job.
You're a patient or a person facing person. Exactly. You have to have an element of joy in what you do. So really try and enjoy it. And again, one of the best bits about neuro is that you can use all sorts of tools, to have fun with.
Yeah, and
there's lots of, I don't know.
You can see something in the background as well. We've got a petition away, but there's tons. You can anything you can.
There's lots of stuff that can help try and get somebody engaged in their therapies. That's beyond that of a TheraBand perhaps. It's lots of things that you can use, loads of tools. So have fun with them, find things. We've got a trampette behind there. There's nothing more fun than putting someone a bit wobbly on a trampette.
Exactly.
Seeing what happens.
Enough with them, not happen.
with them always.
Amazing. Alice, thank you so much for your time. I've got one more question before I ask a few people this. And it's going to be a difficult one for you, because I know you've always wanted to be physio, neuro physio, but if you were going to do anything else as a career, what would it be? And I haven't prepped Alice for this one. So
you actually want to know the answer?
Yeah, I do want to know the truth.
I probably would be a PE teacher.
PE teacher?
That's probably not a massive shock.
It's an answer, I suppose.
Because no, I mean it's probably not a massive. It's probably not a massive shock, because again, I would have to be. Yeah, it would be something to do with teaching. Yeah. Because I enjoy teaching in this job role now.
Exactly. Yeah.
I love the learning development side of stuff, and but then teenagers are a nightmare. I don't know. I think I would have. I will stick with PE teacher, I think.
Fair enough. And last, cats or dogs? Go.
Dogs.
Fair enough.
I've got a dog. You know that. I can't say cats. I almost reflexively said cats and thought I don't have any of those.
Amazing. Well, first face-to-face interview that we've done. I hope it's gone well. I've had great fun. And
thank you, James.
It's been brilliant. And I also like to take this opportunity just through across the whole channel as well to thank you for the time I've had on my rotation, because it has been.
It's been a pleasure, mate. Thank you.
Absolutely amazing. Alice is on Twitter. I'll put the link below if you want to follow her. She's doesn't use it all the time, but you do put bits out, especially to do with Plym Neuro as well.
I do, yeah. So you can follow Plym for more Plym related stuff. You can follow me for some football related stuff as well, because it is a personal Twitter account, not just a professional one. But it's both. There will be both. There is some neuro geeky stuff out there too.
And just like all the other with Twitter, this is what I love about Twitter, is if you follow Alice and you follow Plym Neuro Rehab Unit as well, you'll then get suggestions for other people
exactly.
too. And there's some of the MDT here that are also on Twitter as well. Yeah. So check it all out. Fantastic. So that's neuro placements all wrapped up. So thank you very much for watching. We're going to wrap it up straight there. Thank you again, Alice.
No worries.
And
thanks,
I look forward to seeing you for the next video. Thanks, everyone. Speak to you soon.